صباح الخير جميعا. Today we are going to talk about hypertrophic pyloric stenosis. The pylorus is the muscle that lies at the end of the stomach, separating the gastric antrum from the duodenum, first part of the duodenum. Abnormal thickening of the gastric muscle or the pyloric muscle resulting in functional gastric outlet obstruction. This is the definition of hypertrophic pyloric stenosis. The etiology is unknown. Presentation. The typical age of presentation of infantile hypertrophic pyloric stenosis is between the age of 2 and 8 weeks post gestation. So if the baby was born preterm, you have to calculate the post gestational time. It's non-bilious emesis. The formula will be undigested, and usually it's projectile, as you can see in this picture. The mother will describe very dramatic kind of vomiting. And the baby usually hungry between the episodes of vomiting and wants to feed. On examination, the baby typically is dehydrated, has sunken eyes and fontanelles. The mucous membranes will be dry, and you will notice poor weight gain in the last few weeks since the symptoms started. On the abdominal examination, you can see visible gastric peristalsis because of the gastric muscle is working so hard to push the content, and usually in transverse fashion from the left side to the right side. If you feel carefully, you can feel an olive mass just below the costal margin on the right side, which represents the hypertrophic muscle. Investigation: labs, electrolytes, low chloride and low potassium is very typical, and the blood gas you can see metabolic acidosis, metabolic alkalosis. The description usually hypochloremic, hypokalemic metabolic alkalosis. How did that happen? With the progressive vomiting, this will cause dehydration and low sodium body content, which will increase the aldosterone secretion, causes renal tubules to reabsorb sodium and excrete potassium, which result in hypokalemia. At the same time, vomiting will cause hydrogen ion loss. This will cause the potassium to shift intracellular exchange of hydrogen ion, which will cause hypokalemia as well. Low hydrogen ion will cause alkalosis. The vomiting, the chloride in the hydrochloric acid will be lost, which will result in hypokalemia. The kidney will reabsorb more bicarb because it has negative charges to keep the total negative charges in the body. So this will cause more alkalosis as well. Going back to the low potassium, potassium is very critical for the cardiac function. So when the potassium is critically low, the renal tubules will reabsorb potassium in exchange of hydrogen ion, which will cause paradoxical aciduria. Imaging. Abdominal X-ray usually not helpful, but you can see very big dilated stomach, and the rest of the bowel gas pattern is unremarkable. Ultrasound is the gold standard test looking for the pylorus. We are looking at the length of the pyloric muscle and the thickness of the pyloric muscles. So this is a longitudinal view. The length of the pyloric muscle, normally it's less than 14 millimeter. If it is longer than 14 millimeter, then it's considered long. And the thickness, you are looking at one side. This is the pyloric channel, and this is the thickness of the upper part of the pylorus, or one side of the pyloric muscle channel. And you're looking for thickness more than 3 millimeter to consider it abnormal. Just remember by 3.14. So if the thickness is more than 3 millimeter and the length is more than 14 millimeter, this is considered abnormal and hypertrophic pyloric stenosis picture. Upper GI contrast study is another way of doing the test. It's rarely done because the ultrasound is very good. You can see a string-like picture of the pyloric muscle and dilated stomach proximally and normal duodenum distally. How to manage patient with pyloric stenosis? First thing is correct the dehydration and electrolyte disturbance. So how to rehydrate the patient? Give him normal saline boluses, typically 20 ml per kg, normal saline. Then start D5 or D10 half normal saline maintenance. Once the patient passes urine, so you know for sure he is not having renal failure, then you can add potassium to the IV fluid maintenance. You typically have to repeat the electrolytes and the blood gas every 6 hours until they are corrected. Aim for chloride of more than 100 and normal blood gas, normal pH and normal bicarb. Keep the patient beyond the time being. Sometimes you need to insert NG if the patient has persistent vomiting. And once the electrolyte is corrected, then you can book the patient, which usually takes a day. Then you can book the patient for surgical treatment. The surgery is pyloromyotomy. It was described by Dr. Ramstead more than 100 years ago. The pyloric muscle has the circular component, which is hypertrophied. So you're trying to break the integrity of the circular muscle of the pylorus with keeping the mucosa intact to prevent perforation. How we do that? There's two ways of doing it. The most common way is open technique through small pre-umbilical incision. You find the pylorus and then you make an incision longitudinally in the pyloric channel, and then you spread the muscle, the circular muscle, and keeping the mucosa intact, making sure the muscle is completely broken down by doing independent movement of the two sides of the pyloric channel, pyloric muscle sides, and you can do that laparoscopically as well. Now with the laparoscopy, it's very hard to make sure that the myotomy is complete, and it's difficult to test the mucosa to make sure there is no perforation. The procedure takes about 30 minutes, and the patient can be fed orally right away after the procedure. Complications: incomplete myotomy, as we mentioned. If you don't break the muscle completely, then the patient will have persistent symptoms, and the main way to prevent it is to make sure the myotomy is complete intraoperatively. And mucosal perforation, as we said, it's very important to make sure the mucosa is intact and there is no perforation of the mucosa. Shukran. بالتوفيق.